Hi, everyone. Thanks for joining us this morning. We're going to go ahead and get started. Just for a reminder, if you guys are watching together as a practice team, please be sure to chat in all the individual team members so that we can grant everyone credit. This is the first session of the next learning community segment in behavioral health. This is 201. Just a few housekeeping items. To participate in the meeting, please click on participants. Feel free to raise your hand if you have questions. You can also chat with us by clicking the chat button at the bottom or top of your bar for the Zoom meeting. To start your video or to stop your video, click or unclick the camera in the bottom left. And just to disclose, we have no financial relationships and nothing to market throughout this presentation. Jonas, do you want to take it away? Okay, so for this presentation, it's a little bit different than what we did for 101. We do have some Zoom interactive polling slides where we'll ask a question and you'll see a poll pop up on your screen. All you need to do is click your answer. You'll have about 20 to 30 seconds to do so, and then we'll show the results.
I figured out how to unmute myself.
Great.
Today we begin this module on substance use, and when we originally did this learning community, we had 2 sessions on that, and very quickly realized we needed more, and we went from doing 4 hours of content. We now have 10 hours of substance use focused content in our education programs, a large amount of which you'll participate in through this course. Given the number of kids that we see that have anxiety and depression and that have co-occurring substance use problems, this is becoming more and more important. Yesterday I was in Barnes & Noble, and alongside Entertainment TV magazine and Wedding magazines was the complete guide to medical marijuana. So this is what we're facing, and I pick up one of the local papers here and, you know, very easily find an ad. You know, fast, convenient, easy, get your marijuana card. I mean, this is not a car wash, fast, convenient, easy. I mean, it's like, you know, this is pot, and this is, you know, becoming omnipresent. And so this is a really important module and, you know, really important to the work that we're doing. I'm not going to spend a lot of time talking about the growth of our partnership with the ASAP program. There's other, I think you guys may have heard about some of that in other ways, but I want to introduce Mimi Shizer, who's been our core faculty member for this module from the beginning and has a host of other roles as a consultant. If you call the ASAP consult line, she may be one of the people you speak with. She's our trainer for medication-assisted therapy and contributes in just a wide variety of other ways as a active clinician in the ASAP program. She's a gifted instructor, so I think you're going to enjoy this module and what she presents to you. So. Welcome, Mimi.
Thank you, Joe. Good morning, everyone.
Good morning.
Am I controlling? Oh. Doesn't want to move. Ah, okay, great. I'm one of the least technical people you'll ever meet, so I've got a little anxiety right now. It is really nice for me to be here. I was realizing that this is my 6th year of starting this curriculum, and it's really been an honor and a privilege working with the PPOC. Our topic today is adolescent substance use. Who knows this term ESPERT, what we lovingly call ESPERT? Hopefully that's familiar to all of you, and that's what we'll be discussing today. We're going to be talking about screening, brief intervention, and referral to treatment for adolescent substance use in the pediatric primary care setting. So I have many objectives for today's session. I'd like to start with an overview. So we're going to think about the epidemiology of adolescent substance use and then really zero in on some of the short and the long-term consequences. And it's almost like I'm making a case for why substance use should have a seat at the table when you're doing a physical or well visit and you've got 100 other things to do, why this should be included. Then we're going to focus on a screening tool, the S2BI, which will allow you to very quickly and accurately assess the risk associated with substance use. That's really what we're relying on it for. And then we're going to finish the 2-hour session by thinking about the brief intervention. Remember the BI in SBIRT, which will allow you to hopefully either prevent, stop, or at least reduce substance use in your adolescent patients. All right, so I'd like to warm everyone up with a case. We're going to be thinking about Trevor. So Trevor is a healthy 17-year-old who comes in for his annual physical. Whoops. Is someone else controlling? Okay, well, I remember what the slide says. So he is finishing his junior year in high school. He's about a B-plus student. He plays 2 varsity sports, so he's doing well in multiple domains. His primary care physician views him as low risk because his drinking he describes as occasional, and he has no history of illicit drug use, and he's, as I said, doing well in school and sports. And he's looking forward to starting to look at colleges. Jonas, this is giving me a hard time. It just seems to want to ignore me.
Yeah.
You have to click on your screen.
You're clicking on, there you go. You have to click on the actual slide.
Okay, and then I just use this?
Yeah.
Okay,
Yep,
seems to be working.
Yep.
All right, thank you.
No problem.
All right, so you've had a time to read now. 1 week after the appointment, Trevor is at an end of the school year party with a few friends, and he has a couple of beers. On his way home, his car jumps the curb and slams head on into a tree. Trevor is pronounced dead at the scene. On autopsy, his blood alcohol concentration is 0.24, which is 3 times the legal limit. It's funny, I still get goosebumps when I read that slide. So this is really a reminder that there's no safe level of drinking for adolescents. We know that drinking by older teens is common, and we can't stop all of it, but certainly failing to give clear health advice not to drink is a missed opportunity in primary care. All right, we're going to start the live polling. So this is something new for me, but it'll be really nice to get feedback from you guys in real time. So the first question is, we'd like to know about approximately what percentage of your patients age 12 and up are you screening for substance use during well visits? So as we start thinking about SBIRT. Okay, now someone else is controlling this. Did you launch the poll?
And then we'll do a survey in the room.
The poll's launched right now. People are answering right now.
Great, thank you.
Can you see the results?
Yep.
Okay, great. All right, so it looks like we'll say about 2/3 are screening all their patients. So I think you folks in the room can't participate. Do you want to do a show of hands? Oh, so what percentage? So we'll do it, so roughly 1/3. Okay, moving up to 2/3 of your patients get screened. All right, so I see a few more hands. Say it again.
If it said 13 and up, it would be all.
Oh, okay, so the 12 and up was a complication, and then all patients 12 and up. Okay, all right, so I think that lines up fairly well with these numbers. All right, can we see the next question? Oh, do I advance?
Yeah.
So we close this one?
Yeah, and then just click on the screen and advance the slide.
Do you want to do it? All right, so the next question we're thinking about is, how do you screen your patients for substance use? We should see the answers in a minute. Can you launch the poll? Oh, that was the last set. Can we get the next set of answers? All right, fantastic. So it looks like the majority are using the S2BI, which is what we'll be talking about today. So that is great. Quickly, the folks in this room, so anybody using the craft for screening? All right, S2BI?
Is that what's in, I mean, I go right through the Epic, I go right through the questions.
That's what lives in Epic, right?
Craft and S2BI are in Epic. But S2BI is built into the template, yeah.
Thanks, if you want to.
I just want the microphone for Joan.
Okay. All right, anyone in the room use a different screening tool other than what's named? And then anyone prefer not to use a formal screening tool? Okay, thank you, everyone. All right, so I'm closing this. I think we have a couple more questions. Okay. Can you launch the poll? So now we're thinking about barriers to screening. And meanwhile, you all are thinking of your answer. All right. Hey, this is very helpful, and I think this mirrors what we see in the literature. So it looks like insufficient time is a significant barrier, not sure how to screen, and then, again, we hear this theme a lot. If I get a positive screen, I don't know what to do. So it kind of, the screening dies on the table. And then nobody checked uncomfortable talking to adolescents about substance use.
I guess I'm curious, what other barriers, are there other barriers that people perceive? You can either say what they are, or if you're remote, chat it in. Other than those barriers you saw, time, not knowing what to do, those other things, what else? Resources being far and few between.
That's the really number one.
Yeah, so what to do with these kids once we find them? Okay. Okay.
Okay, thanks, Jonas.
Yeah.
Okay, I think this is the last of this series of questions. How comfortable are you talking to your patients about their substance use? Can we launch the poll? Oh, great. All right, session is over. We're all set for today. All right, no, I'm very pleased. So the majority says that they are very comfortable. How about in this room? I left you guys out the last time. So anyone very uncomfortable talking to their patients about substance use? Okay, no for that. Slightly uncomfortable. Okay, somewhat comfortable. That's a little bit more measured. And then very comfortable. All right, fantastic. That's really nice to hear. All right, so we have a few more questions later in the talk. Thank you to everyone who participated. All right, so now we're going to go back to epidemiology and an overview of substance use. And that's actually one of the funniest typos I've ever seen, leading causes of morality. There's a T that's missing from that word. Funny, I didn't see that. So just to, yeah, it makes us all sort of think about morality. All right, so thinking about consequences of substance use. So this is data from 2015. I'll tell you that it really changes very little from year to year. And we're looking at causes of death in this age group that's defined as age 10 to 24 in the United States. You'll notice that by far the leading category is unintentional injuries. Some years that's broken down to motor vehicle accident, which is a kind of a whopping percentage of that percentage. This is followed by suicides and then homicides. And you'll notice that if I add up those numbers, that's about 70% of the mortality in this age group. So they're really not dying from strictly medical causes. So all of these have a behavioral component, and I think you'll all believe me when I say that substance use is linked independently to each of these categories. All right. Because I'm going to just, okay, thanks a lot. All right. All right, thank you. So zeroing in on the phenomenon of motor vehicle accident, what you're looking at on the x-axis is the blood alcohol concentration and then the relative risk of having a motor vehicle accident. And I will tell you that these are fatal. These are deaths associated with car accidents. And what you can see on this slide is that age groups are not created equal when it comes to fatalities. And so really heading the list would be the 16 to 20-year-old males. There are two different time periods looked at, but you can see that that's definitely consistent over time. And it really is intuitive that for inexperienced drivers, when they're under the influence of any substance, including marijuana, they're going to be much more susceptible to being in an accident. Okay, let's see if it works. All right, thank you. So we're getting more sophisticated looking at this phenomenon called drugged driving as opposed to drunk driving. We still don't have the data set that we do for alcohol and motor vehicle accidents, but certainly what's emerging is that for drivers, again, you're looking at drivers in fatal motor vehicle crashes, among the drivers that are tested, usually about 30% test positive for substances, and marijuana is on top of that list. So something certainly to think about in the current climate. Okay. Okay, then I can figure it out. All right, thank you. So I'm going to be talking today about the Monitoring the Future survey. How many people, certainly in this room, are familiar with the Monitoring the Future survey? Okay, I see a couple of hands. It's a really valuable tool. Researchers based in the University of Michigan have been doing questionnaires on 8th, 10th, and 12th graders, what they consider a nationally representative sample, on the order of about 50,000 a year since 1975. And these students are asked a variety of questions about their substance use and also their attitudes towards substance use. So it's an incredible wealth of data that we have now for over 40 years, and it's a very nice way to compare trends in substance use. So I want you to zero in on what I'm showing you now. This is from 2017, and I told you they survey 8th, 10th, and 12th graders. Right now we're looking at data for 12th graders. And what they do is they'll say, have you ever used a substance? For alcohol, it would be more than a few sips. And if you answer yes to that question, you're counted as a lifetime user. And then if you look at the column on the right, students are also asked if they've used a substance in the past 30 days. And if they answer yes to that, then they are considered a current user. And you'll see that throughout the literature. Right, so I'm going to repeat the question. Yes, so this is described as using a prescription that wasn't prescribed from you. The question was, does this make a distinction between prescribed medication and misuse, prescription misuse? Yes, excellent question. So what I want you to look at for 12th graders, if you look at a lifetime use of alcohol, have they ever used alcohol, you'll see that that number does come in over 50%, it's about 60%. Whereas if you look at what percentage of 12th graders have used alcohol in the last 30 days, that number falls to about 30%. Then I'm going to ask you to look down a couple of lines. We're going to look at the marijuana set of data. So lifetime use of marijuana for 12th graders is 45%, again, less than 50%. And how many 12th graders have used marijuana in the past 30 days? It's really only about 1 in 5. And the reason I'm framing the numbers this way is Certainly, a lot of adolescents will say, you know, it's that mantra, everybody is doing it. And we have parents that come to our program, to ASAP. They have that deer in headlights presentation. Is this a problem or isn't it? Because my teenager is telling me everyone does it. And I like this information because I think it's grounding for all of us, that not everyone is actually doing it. It just doesn't like me today. Show me what you're doing. So the one on the left?
Yep.
Okay. Okay, I'll try the left. All right, so,
We're just going to minimize that there so you can see.
yeah, okay, and I'll just use the one on the left. Okay, thank you. So similar information. This is from the Youth Risk Behavior Survey, which I'm sure many of you are familiar with. And we're looking at all high school students. We're lumping them together, and we're looking at alcohol-associated risk behaviors. And everything that you see on this slide reflects within the past 30 days. So for high school students, it looks like about 30% have had at least one drink in the past 30 days. It looks like between 10 to 15% are endorsing heavy drinking. Very concerning, about 5% are reporting driving after drinking. Think of Trevor. And then equally dangerous, about a little over 15% are endorsing being in a car when the driver had been drinking. Okay, it worked. All right. So certainly we're all aware of the link between alcohol and sexual assaults. This was a study done out of Brown that looked at the percentage of college students who were involved in a date rape that reported that alcohol was involved. And you can see 50% of females said that was a factor and 70% of males. There's a real morbidity associated with this phenomenon. Okay. I like this slide because it gives you a general overview of the negative consequences associated with substance use. We've already talked some about injuries, both intentional and unintentional. We're certainly seeing an uptick in emergency room visits associated with substance use, particularly with marijuana. I would like to say to the audience, by way of a kind of a tease, is that our session in October will focus exclusively on marijuana and nicotine vaping. So really more to follow on those fronts. We know that school failure is associated with substance use. Certainly the patients that come to ASAP, there's very often a component of declining academic performance, sometimes progressing all the way to school failure. Violence is a correlate, and this can lead to arrests, incarceration. We have a number of patients in our program who are court involved for one reason or another. We've mentioned this phenomenon of sexual assaults, unprotected intercourse, and then that, of course, can lead to sexually transmitted infections, including HIV. And one of the points I like to make about this slide, we're going to talk about patients with severe substance use disorders, but you can you can use once or twice and you can still end up with one of the consequences on this list. All right, this is a really important concept for this audience. And what we know in general is that the younger an adolescent is when they initiate use of a substance, the more likely they are to have, I think in lay terms, a problem with addiction. This is very concerning data. On the left, you're looking at alcohol, and the x-axis tells you the age with which one begins regular drinking. So if you're talking about a 12-year-old with regular drinking, they would have almost a 50% chance of, this was an older slide, so alcohol dependence, as it used to be called. So sometime in their life, they're going to have a severe problem with alcohol. And we know that if they can delay initiation of alcohol use, it doesn't go to zero. You'll see for someone who starts drinking when they're 21, there's still about a 10% chance. But you can see there's a big difference between 50 and 10%. And the curve for marijuana is emerging very similar. I like to make this point because for this audience, any efforts that you could make to delay initiation of substance use in your population is a very powerful intervention for this reason. All right, so in ASAP, we spend a lot of time talking to our patients and their parents about this phenomenon of the teen brain and adolescent brain development. I'm not sure you guys can see the small part, but again, what looms large in the adolescent brain? You've got the emotions, sleep center, sex, music gland, and can everyone read what's at the front, that very small section? Common sense, it's like an eye checkup. So common sense, we have this understanding that the brain develops from back to front, and so sitting there right in the front of the brain is the prefrontal cortex, which is your executive function, impulse control, delay of gratification, all those things. And so adolescents are making decisions about substances with a very different brain than you or I would make a decision about. There's another version of this cartoon which I really like. When sitting in that front portion is a picture of the parents, because they really function at this age as the prefrontal cortex. I also like this slide because we know that adolescents are more susceptible to harm from substances compared to older individuals, and this really has to do with their susceptibility because their brain is still under development. This is a well-established principle, really in medicine in general, that when something is developing, it's more susceptible to harm. So again, just a few words about each substance. This is the molecular structure of ethanol. I don't know how many people in the room or in the audience are aware of this, but we know from rat studies, because you can't really do these studies on humans, that adolescents respond differently to alcohol. And what I'd like you to understand is the effects on judgment and cognitive function are equal, but adolescents do not seem to have the same degree of sedation and motor impairment after drinking for comparable levels of intoxication compared to adults. So this means, A, they're often not aware of the extent of their impairment, and B, they're more likely to get into situations that are potentially harmful, such as getting behind the wheel of a car or having unprotected sex, or kids tell me about sending drunken texts. That's something that they do. There's even a name for that. And very important point, we know that adolescent drinking does not look the same as drinking in older individuals. In fact, 90% of alcohol consumed by underage drinkers occurs in the context of a binge. Generally, we define binge drinking as the amount of alcohol needed to bring the blood alcohol concentration to 0.08 or greater in about a 2-hour time period. And for adults, this is defined as 4 drinks. I think it's 4 drinks for women, 5 drinks for men. If you're talking about younger adolescents, you would want to adjust those numbers downward. All right, so lots more to say about marijuana in October. I like this picture. I think a picture is worth 1,000 words. Generally, we'll talk more about the endogenous cannabinoid system. So we have cannabinoid compounds naturally occurring in our bodies and our brains. We'll talk about what they're supposed to do, but the end game is that there is an abundance of THC receptors in the brain. So really just look everywhere you see a pink/purple dot is where THC binds in the brain, and it really gives you a sense of the extent of how much of the brain is affected. It's always interesting, I always like to point out that you'll notice an absence of receptors in the brainstem, which is why we don't see overdose deaths per se the way that we do for opioids. There are lots of other harms, so that's not a comment about how benign it is. All right, we know that THC has a very significant effect on working memory. This is both a short-term effect and a long-term effect for chronic users, and we know that neurons in the hippocampus are eventually lost if they're continually suppressed. One of the things that's emerged over the last few years is people are doing more anatomical studies, looking to see if they can demonstrate anatomical changes. And the answer is for heavy marijuana and alcohol use, you can actually see shrinkage of the hippocampus. So you can actually track changes anatomically with chronic use. So I'm sure many of you have high-functioning kids and parents in your practice, and you're looking for things to say about marijuana that will resonate. This is a very powerful study that was published, I believe, in 2012, showing that persistent cannabis users have a neuropsychological decline from childhood to midlife. This was a study that was done in Dunedin, New Zealand, where they looked at a birth cohort of about 1,000 individuals. I'll show you the next slide. So they did neuropsychological testing at age 13, and then it was repeated again in the late 30s. And then during this window, they did periodic testing looking for what was then called cannabis dependence or a severe cannabis use disorder. And what they noticed is for individuals who didn't have a history of cannabis use or cannabis dependence, there was no change in IQ, which is essentially what we would expect. And for individuals, particularly those adolescents who were using heavily in the adolescent young adult window, they did see a significant decline in IQ from these 2 age groups. So I would encourage all of you to look at this study and be able to talk about it with your patients, because it does get people's attention. There's a lot in the literature about long-term psychiatric effects from marijuana use. You know, just as a tease for our next session, we know that marijuana use is associated with an increased risk of psychosis and schizophrenia, particularly we know in individuals who might be otherwise at risk and it's also linked to anxiety and depression in adulthood. All right, I like this slide. Amotivational syndrome. I was never a Latin scholar, but I do remember that A in front of a phrase means lack of. So we see this all the time in ASAP. Patients with heavy marijuana use lose their motivation. And often they don't see it, but everybody else does. These are kids who were playing a sport, they stopped playing a sport, had a lot of friends, now have a very small circle. It really is a pervasive phenomenon linked to heavy marijuana use. This is an important slide. I don't know how many people are aware of this. The potency of marijuana has increased dramatically in recent years and recent decades. When I talk about potency, I'm referring to the percentage of THC in the marijuana product, whatever that may be. If you're looking at this slide, you could see around 1990, and literally the DEA will seize marijuana from the street and then they'll assay the percentage, and that's how we have these numbers. So it was tracking low in around 1990, it was about 4%, and then you can see the shape of the line that it's gone up to about 10 to 12%. So you might have families in your practice in which the parents used marijuana when they were teenagers, and they're assuming that their adolescent is having a similar experience, but it really is a different drug than it was in the 60s or 70s because of this change in potency. All right. So the tobacco/nicotine story, we know that adolescents are the target audience for big tobacco because if kids will pick up this habit in their adolescent years, it is then very hard to stop. I think about 90% of adult smokers who are smoking today started when they were adolescents. And we know that there are risk factors associated with smoking. If you monitor these kids, they're more likely to use alcohol and marijuana, they're more likely to use other illicit drugs, and then also engage in unprotected sex. So certainly the story has morphed. Instead of talking about cigarette smoking, we'll be talking much more about vaping. In the October talk, you know, you'd have to be living under a rock to not know the extent of this epidemic. So this is data, again, monitoring the future, one of my favorite sources of data, looking at vaping. And again, the word is very confusing. Kids will use the term vaping. You're not always sure if they're talking about nicotine or marijuana, which is something to be aware of in your conversations. But you can see about 2 in 5 12th graders have vaped in the past year. Sometimes they're vaping nicotine, sometimes they're vaping marijuana, sometimes they're vaping just flavoring, sometimes they have no idea what they're vaping. So anyway, so there's a big story about that, and we'll talk about that more in October. All right, so we're going back to a couple of poll questions just to kind of keep you guys interested and to give me information. So this is more of a trivia question. I'm wondering if you guys know, back to that last question. So what's the number of states in the U.S. as of, what day is today, September 19th, that have now legalized recreational use of marijuana for adults 21 and over? I feel like a game show host. All right, so I'm curious who might know the answer. You might guess, and that's fine. So you guys, I don't think they can hear. Anyone want to guess what the number is so that you guys can be involved?
11, 15.
Yeah, who said 11? Perfect. It was 10 and it just became 11. And it should say plus DC. That was too wordy for my slide. Okay, wow, what a well-informed audience. I remember when I first started doing this curriculum, I think it was 4, and then it's been creeping up very steadily. I have my marijuana map that shows certain, colors for those states that have gone ahead. And 5 years from now, who knows what that will look like. All right, if we go to the next question. But, kids are paying attention, and there's this message that if it's legal, what's the big deal? It must not be harmful. All right, so this tracks back to something I just said. So I want you to think about these dab pens. What do you think is the average potency of THC in these devices? These are fairly new. Anyone in this audience want to shout out what they think? Okay, I have a 60. I feel like an auctioneer. 10, 25. Have you heard your patients talk about dab pens? Is that a familiar term? Okay. Okay, interesting. So I'm looking forward to talking to you in October. So a dab pen is a very concentrated form of marijuana. The potency is actually about 90%. That was the answer that I'm looking for. And I didn't want to give that away on the potency slide because I knew I had this polling question. So the answer is we really have no idea what the long-term health effects are for this new entity of marijuana that the kids are using. The other reasons these dab pens are so insidious is they're incredibly discreet. So you can actually be sitting in a classroom and you can, take a hit off of a dab pen. So, and kids are now using more in school than at home. It's been a real reversal because of the technology. All right, last polling question for now. We're thinking about the amount of nicotine in a Juul pod. So again, the language has completely changed when I talk to my patients just over the last couple of years. Anyone in this room want to guess, or does anyone know? 20. Oh, am I giving? I can't tell what I'm connected to. Okay, so great. So it looks like a lot of people knew the answer to this. So one of the good ways to talk to your patients if they're using an e-cigarette is how long does it take you to go through a pod? We have one patient in ASAP that we're really worried about who goes through about 4 pods in a day. And that's just astronomical. We have no idea what the health effects are for that sort of nicotine exposure. Okay, I think we're done with the poll. Yeah, no, absolutely, yes.
My son's freshman roommate was a 3 Juul a day person, and he's actually, by the end of the year, reverted to cigarettes because he wasn't getting enough from his Juul.
Yeah.
He's gone back to
Yeah, no, just to repeat the question. So a freshman roommate who was using 3 pods a day, and then sounds like he couldn't even satisfy himself, so he went back to conventional cigarettes. Yeah, and there's no question we're worried about the pathway of e-cigarette to traditional cigarettes in youth, even though that's the opposite of what they were supposed to be designed for. I think I'm going to hold questions to the end just because we have a lot to get through, but please write your questions down because these are golden. All right, so we're going to segue and we're going to talk about screening, brief intervention, and referral to treatment. All right, so I like to go over vocabulary just so we're all on the same page as we talk about substance use disorders. In the old days, 6 years ago when we were using the DSM-4, the terms that we used were abuse and dependence. I'm sure these are familiar to you all. Remember that when we talk about a substance use disorder, it's always specific for a substance. So by definition, we would talk about marijuana abuse, which was the intermediate term, and then alcohol dependence, which is really a fulminant problem, fulminant alcohol problem. So along came the DSM-5 in May 2013, and I think the feeling was that these terms were intrinsically confusing. And so the psychiatrists, got rid of abuse and dependence, and instead there are 2 categories, either early use that hasn't progressed to the point of a substance use disorder, and the substance use disorder category, which is then further classified as mild, moderate, severe. I spend a lot of time in ASAP going over these diagnoses with families, and I think they're easier to understand. So I prefer the change. So this is not what you're doing as part of your screen. This would be the diagnostic assessment, which is what I do in ASAP. And the screen that we're going to be discussing gives you a shortcut so you can kind of guesstimate this information. But it's good to know what criteria we're using to make these diagnoses. So there are 11 questions in the DSM-5. These are yes or no questions. The more yeses, the more severe your problem with the substance. The way it works is if you give me 0 or 1 yeses, I don't give you a diagnosis. 2 to 3 qualifies for a mild substance use disorder, again, specific for substance. 4 to 5 is moderate, and then anywhere from 6 to 11, kind of a broad category for severe substance use disorder. Spend a minute looking at these criteria just so you can kind of get a sense of what we're scoring when we give someone a diagnosis. Generally, use in larger amounts or longer periods of time. Maybe it's on your radar that you think you should quit and it's harder than you thought. Excessive time spent using, from recovering from use, or trying to obtain. We have adolescent-friendly language that we use to ask these questions. I think that one is, do you spend a lot of time using marijuana like it's a hobby? And the kids that say yes clearly understand the question. Craving was added in 2013. I think it's an excellent question. Do you crave the substance? Is it interfering with your fulfillment of obligations? Continued use despite interpersonal problems. Most of the kids who've come to ASAP have been fighting with their parents, so they will give me a yes on that one. Important activities given up or reduced. Recall amotivational syndrome. I don't like to get yeses to this one. This is recurrent use in physically hazardous conditions. That would be, for example, driving under the influence of a substance. Continued use despite knowledge of physical or psychological problems. Patients do endorse these criteria themselves. I don't get a lot of yeses for that one because these kids don't find the substance use particularly harmful. That's usually a no. And then, of course, there's this phenomenon of tolerance. So you have to use more of a substance to get the same effect, and withdrawal. So you're getting a sense of what we're looking at when we give someone a diagnosis, when they earn that. All right, so Jonas has heard me say this many times. I love this picture. I'm going to show this to you a few times today in our discussion about SBIRT. This is what use of the S2BI, which many of you are already using. It allows you to assign an individual patient into one of these, what are called actionable categories. I always stumble over that word. So let's start at the bottom and move up. The first category is no use. So these are adolescents. When you ask them about use, no, they've never used. It might be intentional, it might not be, but they all fall into that category. As we move upward, the next category would be there is a history of occasional use, but they would not meet criteria for a substance use disorder. So then moving up, for the purposes of SBIRT, it is fine, kosher, encouraged to lump together patients with mild and moderate substance use disorders. In terms of your brief intervention, they're going to be treated the same. And then hopefully the smallest number coming in at the top of the pyramid are patients with a severe substance use disorder. So I'm going to show you this a few times because this is what the screening tool allows you to put a patient into and then do an action based on that. All right. So I always enjoy talking about this age-old question, do healthcare providers really need a structured tool for substance use screening? And I'm enjoying the fact that we've done the polling questions because it seems that most of you are on board using a validated tool. So it turns out that if you look across the country, the AAP did a survey a few years back, and it turns out that both in 2007 and in 2013, only about a third of pediatricians said that they were using a validated tool, and the others were using general impressions. So I'm in the clinical arm of ASAP. We have a research arm that does some really interesting stuff. A few years ago, they partnered with the AAP, and they did focus groups on the healthcare providers who said that they weren't using a validated tool. So they were asked, I think there were about 20 to 25 individuals who were asked why they chose not to use a validated tool. So these are quotes. I don't think Pleasantville, I think that's fictional. But one provider said, you know, it's a very small city. I wouldn't think that the kids are really using drugs and alcohol. And a lot of the phrases that kept coming up is, you know, my patients are good kids. And so my answer would be, you know, good kids are using substances too, as you think about this. I'm being a little tongue-in-cheek, but you understand what I mean. So some physicians just aren't convinced or don't agree on the need to use a validated tool. This is an interesting slide. So someone said, if patients are drinking, it's like stupid high school kids who go out and have a couple of beers on a weekend here and there. It's not like chronic alcohol problems. And really my distinction is that we know that adolescent drinking does not look like adult drinking. Think of Trevor. And so we're not trying to capture this kind of fictional adult patient. We're trying to determine in this adolescent what their drinking looks like and whether it's a problem. All right, I always enjoy this slide. The woman on the left looks like something in maybe a Hallmark movie. And I'll tell you that, you know, if you're looking for any sort of stigmata, you know, what do the patients look like who have severe drug and alcohol problems? They look like the kids on the right. They don't look like the patient. You know, I've been doing this for 10 plus years. There's one woman that comes to mind that looks vaguely like that, but everyone else looks completely normal. Celeste Wilson is a colleague of mine at Boston Children's Hospital. A few years ago, she did a very interesting study that was published in Pediatrics in 2004. And what she did was she had this group of patients who were tested for a substance use disorder using a formal diagnostic assessment. So think of the criteria that I showed you. And then she had healthcare providers weigh in on what they thought was the extent of the substance use problem based on their general impressions. And what you can see is it's sort of a paradox, but particularly as the severity of the substance use increased, providers were less able to pick up the problem. So really kind of puts what you would expect upside down. And that's the reason why we need to use a validated tool. All right, so I told you I'd show that picture to you a few times. So this is what the S2BI looks like, and I understand it is an EPIC, so it is easily accessible. Generally, if you have a way to administer this in a way that it's the adolescent and a tablet or the adolescent and a piece of paper, we think that that works a little bit better because you're not introducing any bias the way that you ask the question. If that doesn't work in your practice, this can also be verbally administered. So what you're asking, so S2BI, it stands for Screening to Brief Intervention, and you're asking patients in the past year, how many times have you used tobacco, alcohol, and marijuana? And really the genius of this screening tool is the frequency question. That's what gives you all the information so that you can assign them to one of the rungs of my pyramid. So for each of these, tobacco, you would say, the 4 categories would be never, once or twice, monthly, or weekly. If that person answers no to tobacco, alcohol, and marijuana, you're done. This person would be at that bottom rung of no use. If they give you anything that isn't a never, then you want to ask them the remaining questions. Again, you're always assessing frequency, and the remaining categories would be prescription drugs that weren't prescribed for you. We had talked about your question about prescription drugs, so that doesn't count if it's your own prescription. Illegal drugs or street drugs, inhalants, and then this category of herbs or synthetic drugs. So really, as I said, what I like best about this screening tool, the power really is that you can use their frequency response to put them in a risk category. And so we know that if they're, for the purposes of this screen, if they're endorsing monthly use of a substance, you can consider them to have a mild or moderate substance use disorder. Anyone who's endorsing weekly use, which certainly could be daily, would be, the proxy would be, think of them as having a severe substance use disorder. All right, so this is one of those busy slides you're never supposed to show, but we're going to spend the next several minutes going over it, so please don't be overwhelmed. So what this shows you is on the top are your S2BI screening questions. How many times in the past year have you used nicotine, alcohol, marijuana, followed by the other questions if indicated. And then remember, today we're talking about SBIRT. So we're talking about the screen, and then what are you going to do with the screening result? So moving from left to right, and we're going to talk about this and we're going to show examples. So patients who have no history of use, the name of the game is going to be positive reinforcement. That's great. Moving from left to right, patients who've endorsed occasional use, then certainly they will get asked the remaining questions, and you're going to give them brief medical advice to quit. That would be the brief intervention. The 2 categories on the right, these are going to be your more involved patients, and so the intervention is going to take a little bit longer. Of course, you're going to ask the remaining S2BI questions, and then in this case, you're going to do a brief motivational intervention. I always want to call that a BMI, but that's taken. You're going to get more information about their substance use. All patients are going to hear you advise them to quit. That's a really important point for today, that no matter what category they're in, except the left one, as your physician, as your healthcare provider, I advise you to quit. And then you're going to try to make a plan with them. Could be a very short-term plan of changes that they're going to make or a follow-up appointment that they're going to schedule. All right, and then as we go to the right, this most worrisome category, which are the individuals endorsing weekly use, they should also get a referral to treatment. That's the RT and SBIRT. All right, so this is really just another way of looking at what are our brief intervention goals, as we just said, and it varies depending on which column your patient is going to fall into. All right, so I certainly couldn't give this talk today without talking about confidentiality. And I'll say that as I do these sessions, some of the most interesting questions I get asked have to do with that confidentiality and safety line and where do you draw it. So I appreciate that this is very nuanced. In general, as you're doing this screen, I would say it is a waste of your time if you're doing it with a parent present. And even if you are doing it in the waiting room with a tablet, I know when I go to my kids' checkups and I'm sitting next to them, you even want to think of the staging, as the parent kind of sitting next to them looking at the responses, then that doesn't count. So adolescents should be spoken to without a parent present. You should always tell them in the beginning, before you start getting the answers, that you're going to keep this information confidential unless safety is at risk. I'm a big believer in Murphy's Law, and certainly the one time you forget to say that is going to be the time when you're going to be faced with a situation that needs disclosure. Certainly this varies by state, so you want to be very familiar with, well, what does the law say that I have to do in some of these nuanced situations? If you're hearing something that you're thinking, I need to share this with the parents, then you want to let the adolescent know. You want to have a conversation in detail about why you're concerned about their safety, and you can reassure them this doesn't mean that everything they just told you is going to be shared. Kids are very concerned about the details, who they're using with, when they were using. They never want you to share that, and we never do at ASAP. It's never at that level that I have to share. And so you would want to practice with the adolescent how it sounds like when you say it. Really what you're doing is you're trying to protect the therapeutic relationship. And again, a lot of the questions I get from this audience is, if I tell the parents this, the patient will never come back. So more to follow, and I know it's complicated. All right, so what we're going to do now is we're going to go from left to right, and we're going to give examples of what this might look like in your patient practice. So patients who you ask about tobacco, alcohol, and marijuana, they deny any use, and then you're going to want to go the positive reinforcement route. All right, so generally we know that positive feedback is a really important tool. In some ways it's more influential than negative feedback. This pearl I really enjoy talking about. So as I said, this could be someone who's never had an opportunity to try nicotine, alcohol, or marijuana. Maybe it's never come up, but there's a certain strategy to framing it as a decision. Like, that's great that you've decided to not use, because it sort of makes them start connecting the dots of, maybe that's what I did. I always like to make the point about norms correction. We do recommend screening children as young as 12, but you want to be careful with your language that when they leave your office, you don't want them to be thinking, does my clinician think that I should have? Do they in some way expect that I would have? The NIAAA, which is the National Institute of Alcohol Abuse and Alcoholism, has a screen that they endorse when you start asking kids as young as 9. And what you do is you sort of tiptoe into the questioning by saying, have any of your friends ever tried alcohol? I don't know if we should be talking to kids as young as 9, but that would be a good example of when they leave your room, you don't want them to be thinking, is that the expectation? So that's what I mean by norms correction. All right, so let's see what this would look like. So Sarah is a 16-year-old girl, and she has no past year use of any substance. So this would be an example of what you could say to Sarah. So again, frame it as a decision. You've made a very good decision not to drink or use drugs, and I hope you keep it up. When kids do use, they tend to get into trouble, like getting injured or even having unwanted sex. And again, your goal for Sarah is, let's say you're going to see her back in a year. Ideally, based on this little intervention, you would like her to return in a year and say that she also hasn't used any substance. And remember, again, if you can delay initiation of use, that's a very important intervention. All right, so we're on this journey moving from left to right. So the next category of patients would be when you ask them about tobacco, alcohol, or marijuana, they're endorsing the once or twice category. So a couple of times, so they earn themselves the right to be asked the remaining question, and then for this category, you're going to give them brief medical advice. All right, so again, all patients, no matter what their category, should hear you say, as your physician, I advise that you quit. And you want to talk to them about health consequences. The research arm of ASAP that I've alluded to before has done a lot of really good focus groups where they actually talk to adolescents and go over a lot of different things and say, when you go in for a physical or when you go in for a well visit, what do you feel comfortable with your provider talking about? And again, this is on the subject of substance use. And the feedback that always comes back is essentially the health effects and the medical stuff. They're very comfortable hearing that from you. And even when you're not sure if you're making an impact, they really are interested in what you have to say. And then we're going to be talking about motivational interviewing later. So this is a kind of a very important refrain that it's always important to use a strength-based approach. Ideally, you're having this conversation with someone, maybe you've known them since they were a newborn, so you know whether they're an academic type, or they're an athlete, or a musician. What is it that's important to them? And you want to find a way to weave that in to make more of an impact. All right, so let's think about Marcus. Marcus is a 16-year-old boy who comes to the office after injuring his ankle at football practice. He's used marijuana once or twice in the past year, but not at the time of this injury. I like this slide because it reminds me to say, mainly we're talking about SBIRT in the setting of well visits, but if you can do it in an urgent care visit, that is great, particularly if there's something about the visit. If they're coming in for a strep throat, I'm not necessarily saying you have to do it, but this is an injury, if it's certainly like an STI concern or something that sort of dovetails close to this category of substance use, it would be a really good idea to do the screening test then. And we know that some of the kids with severe substance use disorders fall off the radar. Maybe they're not coming in for their well visit. So you want to always be an opportunist about thinking when you should do this. All right, so here's Marcus, back to Marcus. All right, so this is what you would say to Marcus. I would recommend for the sake of your health that you quit smoking marijuana. And then what is he going to hear? What's going to be important to him? Marijuana use can affect your concentration. Over time, it can impact your mood and affect your performance on the football field. And here I'm going into my strength-based approach. You're such a good athlete, I would hate to see anything get in the way of your future. And as we go together and discuss this topic in more detail, it would be good if you had a toolbox. And so you had a bunch of different things that you felt comfortable saying about marijuana use and the negative health effects, and then you could tailor what you said based on the person sitting in the room with you. All right, so for those of you who have done the craft or are doing the craft, embedded in the craft is the car safety question. That's the C in craft. And so when we move towards doing the S2BI, unfortunately, we lost the car safety question. So what I'm encouraging all of you to do is to build that in elsewhere, to make sure that all adolescents are getting screened to think about this. So you should tell them that teens should not drive even after a single drink. Often teens don't notice the early effects of alcohol that can affect driving abilities. And please think about the slide I showed you in the beginning with the astronomical risk of motor vehicle accidents for younger drivers as the blood alcohol concentration increases. So in this safe space of a well visit, you can brainstorm with the adolescent. Let's say they're in a situation where maybe they were going to drive home or their driver and there's alcohol or drug impairment getting in the way. So what could they do if that happens to them? Certainly they could get a ride from a non-user. Always a good idea to stay where you are overnight and then drive home in the morning. And then my personal favorite is to call for a safe ride from the parents. How many people in this room are familiar with the Contract for Life? Okay, some years more than others. So this is a wonderful document. It's available online. It's published by SAD, Students Against Destructive Decisions. I think I have a picture of it on the next slide. All right, so, I encourage you to take a look at it. Generally, the young person is agreeing never to drive impaired or to be a passenger in the car when the driver is impaired. And the adult is agreeing to always be that safe ride, no matter what the context of the call, what time, where their child is, that they will get in their car and they will go get their child. And then one of my favorite little loopholes in this contract is they also promise that there won't be any discussion of the events surrounding the phone call until the next day. And I've had many patients, when I'm discussing this with them, basically tell me that they would never call their parents because their parents would scream at them. And so going over this contract in a moment when this isn't an issue, I think is a great intervention. And I remember one year we did this session and I found out that one of the practices was routinely handing this out to adolescents in well visits, and that just made my day.
I also think the third sentence in the parent contract is really important. That the parent is pledging not to do the same. And,
Absolutely. Yes, thank you. No, I'm putting on my glasses. So absolutely. So a comment from the audience that if you look at the last line, I also pledge to you that this is the parent section, that I will not drive under the influence of alcohol or drugs. I will always seek safe, sober transportation home, and I will always wear a seatbelt. Absolutely. Thank you for highlighting that. All right. So we are about halfway there. Of course, now we're doing the more involved set of patients as we move from left to right. So now we're talking about the category of patients that you do the S2BI and they're endorsing monthly use of nicotine, alcohol, or tobacco. So they get asked the remaining questions. And then what you do with these patients as part of SBIRT is going to be a little more involved. This is what I call the brief motivational intervention. Really what you're looking for in this very short exchange is what problems have they had associated with their use. That's really what you want to kind of have a radar for hearing. And then you want to advise them to quit. I'm going to say this one more time. All patients should hear you say that. and then you want to assist them with a plan. And if they're not agreeing to quit on the spot, then if everyone knows the phenomenon of harm reduction, which is, well, they're going to continue to use, but you're going to try to eliminate any high-risk behaviors or at least get them moving towards decreased use. So we're going to go over this category now in a little more detail. All right, so for this brief motivational intervention, it is going to take a little longer because there's something there that you need to discuss. So you're going to ask them questions. And again, you're looking to identify problems that they've had associated with this substance use. These problems are going to become a pivotal point in the conversation. For those of you trained in motivational interviewing, this is where you're going to develop your discrepancy. Again, you're going to give them clear medical advice to stop and then assist with planning. You know, as part of this BMI, and we're going to look at one in a minute, you're going to have a plan in that moment for them to agree to make some sort of a change. Now, as we move from left to right, it does become more important for parents to be involved in the conversation. So that's going to be part of what you're asking is, can we involve the parents in this conversation? And these patients should be seen for some sort of follow-up based on your conversation with them. I always enjoy going over these questions. It looks like this audience was already very comfortable talking to their patients about substance use, which is great. I would encourage you to really look over these slides. I have one for marijuana too, and these are the sorts of questions I would encourage you to ask. In general, open-ended is best. You're going to get more information, so try to avoid just the yes or no questions. So open-ended, tell me about your use of alcohol. It's really a perfect way to ask the question. We do want to get some quantitative information. How much do you usually drink? Some kids are better at estimating than others. You know, these days there are water bottles and red Solo cups. You know, it's unusual to say, well, this is the number of shots that I drink, but you want to kind of get some quantitative estimate of what they're drinking. Similarly, it's a good idea to say, what's the most you ever had? Along those lines, have you ever had a blackout or alcohol poisoning? We ask patients, have you ever been in an emergency department because of drinking? Here's another open-ended question. This is exactly what you're going for. Have you ever had a problem because of alcohol? So ask them directly. We always ask patients when we assess them, have you ever done anything you regretted because of alcohol? You might hear about, I mentioned drunken texts earlier. Kids will tell me about, quote, hookups oftentimes. Have you ever tried to quit drinking? So that's a really important question, because if they have, you're really going to want to know that story. What made them think it had gotten to the point where they should try to quit? That's exactly what you're going for. And then, does anyone in your family have an alcohol problem? We know in general that there's a very significant genetic component to substance use disorders. So this is information that you're going to want to have. And then the point, is there a patient in the home? Is there a family member with an active substance use disorder? You should know that as well. All right, so these are similar questions. This is for your marijuana assessment. Again, there's that open-ended question. Tell me about your use of marijuana. Have you ever been a daily marijuana user? There's a funny story behind that typo. I was looking at these slides yesterday, and all of the questions said, have you ever tried to quit smoking marijuana? Do you get lazy when you smoke marijuana? And we have to ask those questions differently, because adolescents are fairly concrete or literal, as you all know. And so if someone is using their dab pen, which is technically vaping, and you're asking them, have you ever smoked marijuana? They're going to say no, because in their mind, they're not smoking marijuana. They're using a dab pen. So this just got revised yesterday. And again, be careful the way you're asking the questions. So have they ever been a daily marijuana user? Generally, anyone who says daily marijuana use, I'm thinking severe cannabis use disorder. You can make that shorthand assumption. Have you ever had a problem or gotten into trouble because of marijuana? Nice open-ended question with what you're going for. Have you ever tried to quit using marijuana? Do you get lazy or lose energy? Recall the amotivational syndrome. And when I see patients who have been abstinent for some length of time, and I'll ask them, what do you notice that's different? They always say, I'm not as tired, I have more energy. I mean, without any prompting, that's when I get back, when they've stopped their use. Do you ever get paranoid when you use marijuana? Some percentage of kids will tell us yes. And along those lines, have you ever seen or heard things that weren't there after using marijuana? You have to worry about patients, because of this link with psychotic disorders, patients who are experiencing those symptoms, you're going to have to really have that on your radar. So this is a picture of the craft. I'm going to assume that you're all familiar with it. In this context, I'm not saying use the craft as a screening tool, but I'm saying the craft makes an excellent tool for assessment. So you've got a positive screen and you want to get more information, so you can get a lot of really good information from the craft. There's the car safety question. Do you ever use to relax, feel better about yourself, or to fit in? I do get more concerned about patients who are using when they're alone. They've sort of left the social construct. They're using for other reasons. Do you forget things you did while using alcohol or drugs? Do your family or friends ever tell you that you should cut back? I'm always struck by patients who tell me that their friends are worried about them. That's always a red flag for me, because that means they're functioning regarding substance use at the extreme end of their peer group. That's always an important sign. And then this broad category, have you ever gotten into trouble while you were using alcohol or drugs? All right, so let's demo what this looks like in the setting of SBIRT. We're going to talk about Katie, who has a mild to moderate substance use disorder. Remember, I'm encouraging you to lump those categories together. So Katie is a 17-year-old girl who comes to the office for a physical. She reports past year alcohol and marijuana use, but doesn't endorse use of other substances. And she's comfortable with the monthly prompt to describe her alcohol use. So you're going to say, tell me a little bit more about your alcohol use. Katie tells you that she started drinking at parties as a freshman. Now she drinks about twice a month, 4 to 6 shots, so she's pretty good at giving a quantitative estimate, which she describes as enough to get drunk. Have you ever had any problems because of drinking? Again, that's what we're going for here. Katie tells you she was suspended for 2 weeks because she was drunk at the homecoming game and threw up in the bathroom. This is classic adolescent thinking. She thinks her grades have dropped, not because of this background of alcohol use, but because of that 1-2 week suspension. She's telling you she was never able to catch up. Her parents were upset and they grounded her at the time. She told them that she would stop drinking, but meanwhile she's resumed drinking with friends. Important question, have you ever had sexual contact after drinking? Katie does tell you that she had sex while drunk twice. And in fact, 2 days ago, she had sex when she was drunk. She didn't use a condom, and you can tell that she's worried or she's upset about that. Have you ever tried to quit drinking? Another classic adolescent response. She's never tried to quit. She tells you that she drinks less than her friends, so really by definition, her drinking isn't a problem, and she has no interest in quitting. So realistic answer. So we're going to be talking about the MI approach. You would summarize what she's told you. So you say to Katie, you enjoy drinking with your friends, and alcohol has also gotten you into trouble. Where should we go from here? All right, so you're sort of regrouping in the moment with Katie, trying to come up with a plan. Katie doesn't think she has an alcohol problem. As I just mentioned, she's not interested in quitting. But in this conversation, she tells you that she does think she should cut back and be smarter about her alcohol use. So you were able to elicit that from her. So then you tell her, only you can decide whether or not to drink. As your physician, I recommend that you quit. Kids often get into trouble when they drink. If you're not going to quit, cutting down would be a good idea. And this is classically what we call harm reduction, which is fine in the setting of SBIRT. So this is what you guys come up with. She says she'll limit herself to 2 to 3 drinks, which is a lot better than 4 to 6 drinks. You remind her never to drive or ride with an impaired driver. You ask her not to have sex when she's intoxicated, and she agrees that she'll try. She's really upset about this. And then you make a note to follow up with her individually when she comes in for follow-up. All right, so we've made it to the right part, the part on the right where we're talking about patients who endorse weekly use. The brief motivational intervention is going to be similar to what we talked about with the other category, the second from the top. The only difference is for these patients, remember the RT in SBIRT, referral to treatment, these patients ideally would not leave your office without a referral to treatment. So someone else is going to get involved other than you for this category. All right, so again, some of this is similar. We're asking questions, we're looking for problems, we're giving clear medical advice to stop. And then the difference is we would like to refer these patients to the appropriate level of care. Ideally, parents would be involved. We all know that appointment scheduling and the like will go better if parents are involved, but that's not black and white. You're going to try to incentivize the adolescent to involve their parents if they're not already. I like this slide because it kind of reminds me to say a word about acute safety concerns, things that I would automatically endorse as red flags for safety. Anyone who's been to the emergency department because of substance use, that is, that immediately tells me that's high-risk substance use. Clearly, anyone who's doing injection drug use, this is really the top of the risk pyramid. Mixing sedatives is concerning. Does anyone know what a Xan is? If I said a Xan, what's a Xan? Right, exactly. So there are a lot of Zans in the schools these days. I'm just going to take a quick drink. So, right, water. Thank you. So when I talk about mixing sedatives, the category that's very concerning would be any combination of alcohol, benzodiazepines, that's your Xan or your alprazolam, Xanax, or opioids, because that can be life-threatening. We know that a lot of overdoses are polydrug overdose, so more than one substance is involved. A potentially lethal volume of alcohol. I remember having a patient who wanted to drink 18 shots on his 18th birthday. That didn't go well. So that's the sort of information you're looking for. And certainly driving after use is an automatic safety concern. The column on the right is a little bit different. I describe these as red flags of addiction. Everything on this slide is I should worry a little more about these patients. Obviously, age matters. If you're getting the same history from a 14-year-old and an 18-year-old, you're going to worry more about the 14-year-old in that setting. In the days when we only thought about the craft, remember a craft of 5 or 6, was very concerning. Anyone using a substance daily or near daily, that's a severe substance use disorder. I don't have to do a fancy assessment to be able to tell that. And then blackouts relating to alcohol is another concerning, something you might uncover in the history. All right, so let's do a case of Alex, who's going to be your severe substance use disorder case. Alex is a 15-year-old boy who comes in for his physical, and he's endorsing weekly marijuana use. In these questions, a lot of the patients who check weekly are in fact daily. The people who invented the study decided to go with weekly, this tool. All right, so let's go over the information you elicited from Alex. So he started smoking 6 months ago. He's now a daily user. And again, smoking, I could say vaping. He could be using his dab pen. He uses marijuana when he feels stressed. He often uses alone. Family, his mother's caught him smoking a few times and is now constantly on his case. Alex is pre-contemplative. We're going to talk about stages of change, so he thinks it's her problem, not his. It's just pot. In terms of the trouble question, he does recall being brought home by the police who caught him using marijuana in the woods, but no charges were filed. They probably just brought him to his house. He does admit that his grades have dropped this year, but the only reason he thinks is because high school is harder than middle school, and he won't acknowledge that marijuana has anything to do with that. All right, so Alex does not want to quit, and really what keeps coming up in your conversation is stress. This is what he uses to manage stress, and he can't imagine life without marijuana use. So his primary care physician acknowledges that stress management is difficult, and so this is this beautiful RT, or referral to treatment for Alex. So the PCP suggests that he see a counselor. It could be the behavioral health clinician in the practice to help him with stress management, and then also to discuss his marijuana use because these are so clearly linked. Alex is reluctant but agrees. So that's just a beautiful example of SBIRT for Alex. So using Alex as an example, let's think about whether the parents are aware or not. So in this situation, and I said that mom is on his case, so if parents know about his drug use, then you are still using your motivational tactic to see if he will agree to share his mom in this conversation. So you can tell him, I think this would be a good thing if we told your mom. In my experience, kids do best when their parents or other family members are supporting them. If you agree, I'd like to tell them that you're planning to start treatment, meaning to see a counselor. And certainly in ASAP, we're very comfortable in the role of advocate for the adolescent. So in your private conversation, you are negotiating with them to make a change in their substance use. And then in this alliance with their parents, you want to present yourself as advocating. This is great. Look what Alex is willing to do. Instead of having a big conversation with the mom about how terrible it is that he's using, you want to really put the focus on what he's agreeing to do. We do that all the time. All right, so what if I change the facts a little in this case and Alex's parents weren't aware of his substance use, and you in the moment are trying to decide whether to involve the parents? You always want to do a quick screen in your own mind. Is there any reason why involving the parents would be worse for Alex? And those would be examples where there's domestic violence in the home, or one of the parents has either an active substance use disorder themselves or an active mental health disorder, in which case there are other things you would want to do if you uncover that information, but talking about the adolescent substance use wouldn't necessarily be a slam dunk. On the other hand, if there are no safety issues, then you always want to encourage the teen to involve the parents or other family members. And again, you can be this advocate, you can break the news, you can really promise the patient that the conversation would go better if you're there than if your parents find your dab pen next week and you're not involved. All right, so in this case, the PCP praises Alex and asks permission to invite the mom into the conversation, and he points out that this is really going to make it less stressful for you at home if I can do this today. So Alex agrees, they talk to his mom together, and then mom, of course, is going to make these appointments happen. So it's critical to involve the parents when you can for logistics, as we all know. All right, I'm looking at the time, so I'm going to go fairly quickly over the next few slides because I do want to get to motivational interviewing. One of you had this really good point that perhaps you hesitate to screen sometimes because of this paucity of resources in the community. I'm not going to say it's otherwise. I think we do have work to do to develop community resources, but on the other hand, we still work with what we have. When you're determining level of care, my assumption on this slide is, again, for a patient with a severe substance use disorder, that a referral is indicated beyond coming back to see you. So things that you want to consider, you always want to consider patient and parent preference. If you have recommendations that are equal to you, go with the one that they're more in favor of. Of course, they're going to be more compliant. You always want to think about patients with co-occurring mental health disorder. That will be our presentation in January, so that's a really important phenomenon. Program availability. It's very frustrating for me when I've had a patient agree to go to a higher level of care, and then they have to wait 2 weeks for a space. And sometimes you lose them in that window. So I guess it is what it is. And then insurance coverage. Some programs are covered by insurance and some are not. Just a word about ASAP. Again, depending on geography, I love being in Northampton. This may work or it may not. Generally, we've been up and running since 2000. We're part of the Division of Developmental Medicine at Boston Children's. Hands down, what I like best about our program is that we're multidisciplinary. So we are 3 pediatricians, 4 social workers, 1 psychiatrist. We have 2 addiction medicine fellows this year, which is super exciting. And we participate in that collaborative team approach on the care of all our patients. We do a lot of individual counseling, very focused on substance use. We have a group therapy program that's intermittent. I do a lot of drug testing. It's one of my favorite things. We do have a buprenorphine program for patients with opioid use disorder. And then our psychiatrist is very busy seeing patients who are dual diagnosed. So in general, if this is a patient that needs a referral, it's always a good idea to choose the least restrictive setting that you think is appropriate. You know, you want to kind of negotiate about what they would agree to. And this probably goes without saying, but adolescents should be referred to programs that are developmentally appropriate. You wouldn't put a 13-year-old with 18 or 19-year-olds. I mean, you really want to be aware of developmental milestones. Of course, we have very few programs for 13 and 14-year-olds, so it's complicated, but certainly the age of the patient matters. Outpatient treatment comes in a variety of forms. Counseling is really important. And again, if you have a behavioral health clinician in your practice, that is ideal. If you're looking for therapists outside of your practice, it's always good to vet them because in my experience, some therapists are a lot more comfortable talking about substance use than others. Group therapy is sometimes a relatively easy sell for adolescents unless they have a social anxiety disorder. Family therapy is super important. We know that treating the family is one of the most evidence-based way to go about this problem. This is a family problem. And then as your patient becomes more in need of treatment, we kind of march up the ladder in terms of more intensive treatment. How many people have heard of IOPs and PHPs? Kind of the alphabet soup. Great, and a lot of people tell me that they've used the same construct for eating disorder patients, so it's very similar. All right, so just a nutshell, so an IOP, an intensive outpatient program, these are more hours, places in the community where you're sending patients where, let's say, seeing a therapist once a week, you feel like that would be insufficient. So it's more hours at a time. And then a PHP is really called a day program. I think in the lay press, if someone says, oh, I went to a day program, they're probably talking about this. It's just about as many hours as you could fit in a day of treatment, and then the patient goes home at night. We are lucky in Massachusetts. I meant to look this up last night. I think we have 5 recovery high schools in the greater Boston area, which is wonderful. These are sober learning environments. Generally, the patients who would choose to go to a recovery high school have been battling a substance use problem for a while. This wouldn't be something that you would send a patient to early on, but for patients who really just can't thrive in a conventional high school setting where they're exposed to substances, this can be a really a fantastic way to continue their education. These days, I have a lot of parents who are panicking, and they're taking their kids out of school and getting online degrees. But I think kids are missing out on a lot, and they also have a lot of idle time if they're sitting at home getting their work done online. So that can be a real slippery slope. So this would be an excellent solution in that case. So ART, I told you it was an alphabet soup, acute residential treatment. These are residential programs, short-term, generally for patients who are in crisis. We always use the term for stabilization. Typically, these are dual diagnosis programs, which means these patients are struggling with a substance use disorder and a mental health disorder. Unfortunately, some of these programs are closing. So when you thought it couldn't get any worse, we've been sending patients to Castle in Brockton for many years, and we just learned last month that Castle is closing. So I wish we had more of these programs for sure, but again, we do the best that we can. Residential treatment, so this would really be on the extreme end of the spectrum. Patients who need containment, that's the word I like to use. So typically they've been struggling for a long time and less drastic approaches haven't worked. And so these are the patients that would go for 30, 60, 90 days to a residential treatment facility where they have no exposure and they can relearn life skills. All right, so to summarize our recommendations, so hopefully I've convinced you, if you weren't already convinced, to screen all your adolescents for substance use as part of routine care. We talked about the importance of using a validated tool and making the appropriate level of intervention based on the results of your screen. And then you always want to follow these patients, even if you're referring them to treatment. I would encourage you to stay in the loop and to follow them as well. All right, I think given we're running a little over, so what I thought I would do is break for questions, and then we're going to spend the last few minutes talking about motivational interviewing. All right, so I would love to hear questions. Yes? Someone asked me that a few years ago, and I can get back to you. I believe that there is information that's been published showing that it works. Oh, just to repeat the question, data around the contract of life showing that it makes an impact. And I believe there is. I don't know the number off the top of my head, but it has been looked at. Thank you. All right, we're circulating the microphone.
What do you do when parents approve of their child's marijuana use, especially in the context of anxiety?
No, it's so interesting to me how the landscape is changing. And again, we're going to talk more about this in October. I feel like, I'll repeat the question. So what to do for the virtual audience when parents approve of the marijuana use, particularly if, let's say, anxiety is a factor. You know, I think I end one of my slides next month with Sisyphus, I'm told, who's this character from Greek mythology pushing a boulder, like a very large boulder up a very steep hill. And so to some extent, that's where we are right now. I feel like parents are coming out of the woodwork with their own marijuana use. There's been a big change in the landscape because of the changing marijuana laws, no question. You know, there's no question about that. What I like to do is bring it back to basic principles. And I know what I know, and it boils down to the effects of marijuana on the developing adolescent brain. We also know from the psychiatric literature, and this is very important to explain to patients and their parents, that marijuana might provide short-term relief from anxiety. You know, there's no question that in that 60 minutes after use, you know, you've altered your status. But over time, what it does is it actually shifts the baseline upwards so that the anxiety becomes worse over time. So it really is not addressing the anxiety. You know, this patient should be seeing a psychiatrist, should be seeing a behavioral health clinician, working on the anxiety in some other way. But I have seen, I've seen a focus. I remember our administrative coordinator couldn't believe that a parent was calling to schedule an intake about marijuana use, and the parent was apologetic. Like, is this something I should be calling about? So everyone is really confused about marijuana. But I like basic principles. We know it's harmful for adolescents. Are there any virtual questions? Yes, thank you.
Nope, not online yet. No questions on it.
Okay. All right. So what I'm going to do is, did anyone get a chance to look at the links or the videos that we sent about kind of the bad way to do it and the good way to do it? So I appreciate everyone who looked at them. I've chosen a couple of different ones. Now we're going to look at the ineffective physician and the effective physician. I did a training session for motivational interviewing with Leslie Green, who's one of the ASAP social workers, and these are the ones that she chose to use. Full disclosure, they're not specifically with an adolescent, but I think you can really see what I'm getting at in terms of how to do this. Oh, I think I had a polling question first. Excuse me 1 second. So I'm skipping the case just in the interest of time. I'm picking and choosing. Okay, I guess the polling question came later. So would the folks in Brookline be showing this video? Oh, they are. I see something happening.
Doctors, nurses, and physician assistants all have opportunities to counsel patients about health-related behaviors. As a medical professional, you have a responsibility to talk to your patients about tobacco use and how it affects their health. At times, you will also have a responsibility to talk to them about how secondhand exposure to their tobacco smoke affects other people's health.
Oops, sorry. Sorry. Oh my God. Oh well.
I'm afraid of the computer.
Yeah, me too.
Well, the beginning was just an intro, so we missed that, that's fine.
Don't touch the mic.
Just a couple more back. Perfect. So can we get back on? Oh, yes, that was it.
Nurses, and physician assistants all have opportunities to counsel patients about health-related behaviors. As a medical professional, you have a responsibility to talk to your patients about tobacco use and how it affects their health. At times, you will also have a responsibility to talk to them about how secondhand exposure to their tobacco smoke affects other people's health. These can be sensitive topics, and it is important to keep in mind that the way you approach your patients about these issues will have a big impact on how your advice and concerns are received. In general, it is not useful to confront or scold your patients about their tobacco habits, as that approach is usually not well received by patients and may interfere with your ability to counsel them effectively. Watch what happens as this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand. Anna, I know it is. I mean, everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child? I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Not the scene if they stop talking, because then there's a little
Okay.
more than that.
You want me to pause it right there?
Whatever. Okay.
Okay.
By starting the interaction with an
You can stop that.
I did.
Perfect, thank you. Sure. All right, so who thinks she's going to go home and quit smoking? Yeah, very good, so quit that doctor.
So do you want me to go to the next slide?
Yeah, I think we have a
Okay.
polling question coming up.
Okay.
So one of the things I'm thinking, we're going to find out who's familiar with motivational interviewing. But one of the most important things is change talk. Does anyone in this room? So the idea is what I hear myself say is more influential. Oh, thank you. Sorry. So I'm reflecting on that video. So change talk is really important. That's really what you're going for in motivational interviewing. The idea is what I hear myself say is going to have more of an impact than what I hear you say to me. And so if you watch the video, the woman she's almost explaining why she smokes instead of why she should quit. So it absolutely backfires. Just had to share that because I'm reacting to it. All right, thank you. Give this. All right, so if we could start a polling question, just so I have a background as to who's familiar with MI, motivational interviewing, and for whom this is a new entity. So if we could launch the poll from the previous slide. Perfect. So,
There we go.
okay, that's great. Thank you. That's really helpful. So it looks like most of the audience is coming in the middle, that they have some knowledge of it, they're familiar with it. Looks like I didn't get anyone who's very comfortable doing it. Just to include you folks, so who would say they've never heard of MI in this room? Okay, so I'm not getting anybody. You've heard about it, but you're really not sure much about it. Okay, wow, this is an advanced group. You're familiar with it, and you have a slight comfort level for actually doing it. Okay, it looks like that's the lion's share. All right, anyone very comfortable in this room? Okay, thank you. Good, good, good. All right, so I'll go back to my position. And this is the authoritative book, Motivational Interviewing, which I have at home. I sometimes bring it, but I couldn't find it last night. Thanks a lot. Sure. All right, so why am I talking about motivational interviewing? So for SBIRT, this is really how you're going to do that brief intervention. This is what we're endorsing. And the way I would describe this is an interpersonal interaction in which the primary impact is motivational. So we're talking about a behavior that we'd like to change, and you are using this very brief moment in time to try to make an impact. I like this quote. This is from Milner and Rolnick, the Motivational Interviewing book. And I want you to think about all of the problems that you're addressing day to day, how many of them contain a significant behavioral component. So let's read this quote. It's hard to think of a healthcare setting or professional role, a clinical diagnosis, or a healthcare problem in which patient behavior change is not a potentially important contributor to prevention, treatment, or the maintenance of health. And then they go on to say that everyone is still looking for a magic pill or a medical cure, but oftentimes really there's so much that we can do just by triggering a behavior change. Okay, so I promise this is the last time I'm going to show it, but think about the brief interventions as they vary depending on where you are on this pyramid. We've talked about this. All right, so sounds like everyone had some familiarity with motivational interviewing, so I'm just going to review the highlights. Really, the most important features of it are it's a collaborative, patient-centered form of guiding the patient. And I like starting with a bad example. Was there anything collaborative about what we just saw? The answer is no. Was it patient-centered? Did you even, the only thing she kept saying is it's so hard. but you didn't really get to hear more about her story. So that was an example of what MI is not. So MI, when it's done well, is very respectful, very keeping in mind the patient's own autonomy. And really what you're going after is the patient's own reasons for change. You know, I can give you a laundry list of 100 reasons why you should change, but if you're not generating that list yourself because of what's important to you, it's going to fly out of your head the minute you leave my office. All right, so core assumptions going along these same lines. I want you to think of motivation as a state, not a trait. So my eye color is a trait. That doesn't change from day to day, but my motivation will wax and wane. And we also know that a person's motivation is influenced by interpersonal interaction. So whatever that patient, you know, that mom's motivation was at the start of the interaction, because she was being lectured to, that actually made her motivation decrease to make a change. A very important tenet of motivational interviewing is that we all live with ambivalence. So if we're contemplating a behavior change, it's very normal to live in this large area of ambivalence. Some days I want to change, some days I don't. I really like, you know, this aspect. You know, marijuana is really good for my anxiety. Not actually, but, you know, and so it's living in that ambivalence and then kind of motivating somebody towards the end where they're willing to act. All right, so we do talk about motivational enhancement therapy, which is MI used in hour-long counseling sessions. That's not what I'm talking to you folks about today. I'm really talking about using the principles of MI and getting comfortable with it so that you can use it in these 5-minute or less brief interventions, hence the picture of the toolbox. There are lots of ways to get training. I was looking online for NIDA, which is a wonderful resource. The National Institute on Drug Abuse has resources. If you sit down at your computer and you look at motivational interviewing resources, you can come up with a lot. Certainly if there's interest, we enjoy doing trainings as well. You know, the best way to do it is to come to a workshop where you actually get broken up into small groups and you get assigned a role and then you do it. I mean, until you've actually done it, you can read books about it, but that's ultimately how you're going to learn, by doing it. One of the things I've noticed, and every time I give this talk, the list grows, is that motivational interviewing is appreciated and used in various aspects of healthcare. I had a nice conversation a couple of years ago with a social worker in the OWL program at Boston Children's, which is optimal weight for life, I believe. So kids who have overweight, who are struggling with their weight, go to OWL. And so those clinicians are using a lot of MI techniques for parents and kids for weight management issues. You could see even something like kids who have had organ transplants who aren't taking their immunosuppressants. So I promise you that once you get comfortable with MI, you'll find it's really useful, even, you know, with your family at home. You can kind of manipulate them a little. There's a growing evidence base that MI, specifically in the context of these SBIRT brief interventions, has an impact on adolescent substance use. We're looking at this in a variety of different settings, including primary care, which is what we're focusing on today, emergency departments and schools. So it's one of those stay tuned type of things. I always like showing this picture. I'm a big fan of the stages of change model. In this room, how many people are familiar with it? Oh, actually a fair number of hands. Okay, thank you very much. So this was initiated in the 1970s, and the idea is that behavior change is really a continuum, that there's a cycle. I always think of Elizabeth Kubler-Ross and the stages of death and dying, that this is not sort of yes or no binary, it's a stages of change that one goes through. Generally, I think this was born in the setting of smokers who are trying to quit smoking. I think that's a good way to explain it. So starting with pre-contemplation, let's say in the example of someone who wants to quit smoking, this would be someone who has no intention to quit. They honestly aren't even sure it's a problem. You know, if you bring it up, it's more your problem than theirs. Certainly we have a lot of patients who come to ASAP because their parents are concerned, but I would describe them as pre-contemplative. And we will literally, in our meeting where we talk about our active patients, we'll use these terms because it's a nice way of summarizing where someone is at. So we're moving around the circle in a clockwise fashion. If someone is in the stage called contemplation, that's different than contemplation. That means that they are really struggling with ambivalence. They can identify problems associated with their use, in this example, smoking. So they're on board with why they should probably quit. They just don't have a plan yet to do it, and they're not fully mobilized to do it. As you go around, someone who's in the determination stage, that would be someone who has a quit date. So they are absolutely ready to act. And then the rest of the cycle is great. Someone is in action, they've already discarded all their cigarettes, they're not smoking. Maintenance, I think it's defined by it's been more than 6 months since they made the change and they're doing well. Of course, you can relapse really at any stage of the cycle. I think as we're talking today about motivational interviewing, most of the time you're going to be sitting in the room with someone who's pre-contemplative and you're using your skill set to try to get them towards contemplation. I think most often that's what you're going to be seeing, but it could be someone who's contemplative who you're coaxing towards determination. All right, so MI principles, I'm going to go really quickly. Someone who came up with this loves alliterations. So we're going to talk about expressing empathy, supporting self-efficacy, developing a discrepancy, and rolling with resistance. So I would hope in all of our interactions with patients we're expressing empathy. I don't think MI is that special in that regard, although you did see kind of a dramatic example of a clinician not expressing empathy when she was trying to counsel a patient about a behavior. So I think this is before my time. Someone loaned me that slide. So Sergeant Friday would be apparently a bad motivational interviewer, and it would be more of a cold, distant approach with yes or no questions. Remember, adolescents, you're always going to get a lot more with your open-ended questions. I certainly did watch Columbo when I was younger, and I think he's a nice example of how to do this with more of a sense that we're in this together and let's figure out how to make this work. All right, so hopefully this is a familiar theme, supporting self-efficacy. You know, this is what I was talking about before about a strength-based approach. You know, for this woman, I like to use her as an example. So she didn't think that she could quit smoking. So one of the angles might have been to make her feel that if she wanted to, she absolutely could. And we talked earlier about the importance of a strength-based approach. So that is really one of the important principles of motivational interviewing. Develop a discrepancy. I think this is my favorite. Throughout our talk, I've been telling you to really look for problems that the adolescent has had associated with their substance use, getting suspended from school. Maybe they'll endorse that their grades have fallen, fighting with their parents, because this is ultimately how you will move them towards acknowledging, yeah, I guess that is a problem. That's really what you're going for. And again, this is a patient-centered approach. So it's not you identifying the problems so much as the patient. And there's that change talk that I alluded to earlier. Roll with resistance. This clinician obviously did not know how to do that. You're not supposed to lecture at the patient. If you feel in an encounter that your buttons are getting pushed and that you feel like you want to just tell them what they should be doing, you have to back away from that because that's going to lessen their willingness to partner with you. So roll with resistance. These are not supposed to be heated conversations. These are supposed to be very empathic, non-judgmental conversations. All right, so I'm going to go quickly because I want to show you the effective physician. I think that'll be a nice way to end. So in that MI toolbox that I referred to, these are some of the things that you're going to do. Open-ended questions, reflective listening, affirming, negotiating, reframing, and summarizing. I don't expect you to walk out of this room and have this clearly, embedded in your brain, but I think if you start thinking about these principles, over time you'll become more comfortable. All right, so open-ended questions. Let's look at some examples. And I think each of these is a little pearl about how you would approach the situation. So John is 17 years old. He's been driving a car for the past year. He hasn't had any accidents. However, he often drives home after drinking. And his attitude, classic adolescent thinking, what's the big deal? I can hold my beer. And anyway, my dad's car has an airbag. So that's sort of where he's living with this. And so here's that open-ended question that you would ask. What would happen if you did have a car crash? So you're getting him thinking. Reflective listening. I think you saw this, those of you who watched the videos that I sent. So it's repeating or interpreting what a patient has said for emphasis. We also did some of this in the Katie case that we went over. And what you're doing is you're trying to flesh out their ambivalence. So let's look at an example. Maria is 16 years old. She's been using marijuana with her steady boyfriend for the past year. Her grades have fallen. She tells you, I love Jack and he wouldn't be interested in hanging out with me if I quit. So here's your reflection. So you're kind of summarizing what you heard her say, perhaps with a little twist. So you say to her, you really like Jack and he encourages you to smoke even though you don't want to. So I like that. It's subtle, but it's a good thing to do. And then followed by an open-ended question, what do you think you should do about that? All right, affirming. So this is all about building on a patient's strengths in order to build their self-esteem. So if you're starting to convince them that they should make a change, they believe that they should do it. I don't think we'll have time to look at my ruler slide, but one of the things I like to do in this sort of a session is you can literally have a picture of a ruler, or you could just do a number scale. So there are two ways to do it. So I always ask my patients on a scale of 1 to 10, how willing are you, let's say, to stop using marijuana? So an answer of 1 would be kind of get out of my face, not willing at all, very dramatic no. An answer of 10 out of 10 would be you never want to see it again, and then you find out where they are. And then classic motivational interviewing, if a patient tells you they're a 3, remember a low number means they're not willing, then the classic MI response would be, oh, so you didn't say a 1 or a 2, so tell me about that. You're kind of finding that positive spin so they can start thinking about why they didn't say 1 or 2. Similarly, there's a confidence ruler where you could say, assuming you wanted to quit using, assuming you wanted to quit drinking, how confident are you that you could? So an answer of 1 would mean there's no way you could. An answer of 10 out of 10 would mean absolutely. So again, these are nice tools to have in your conversation, to get information from the patient about where they're at, and also to use that in a subsequent conversation. All right, so Kareem, I've seen many Kareems in my day. He's a 16-year-old boy who comes to your office. His mother insists she's worried about his marijuana use. He doesn't think his marijuana use is harmful, and he doesn't want to make any changes. He spends a lot of time talking about the difference of opinion between his mother and him. So this is what you have. You're going to go for a strength-based approach. So you tell him, I can see that you're very scientifically minded and really did your research. You know quite a bit about marijuana. I know kids who've written term papers about the benefits of marijuana. I always wonder how the teachers feel about that. Open-ended question, why do you think your mother is so worried about your marijuana use? So that's a nice way to frame the question. All right, so negotiation, it involves setting goals that the patient accepts. That's a lot of what you're doing in that little brief intervention is you're coming up a plan that they can leave with. It has to be collaborative. You don't want to just dictate what the patient is going to do. I think you saw that in our discussion about Katie. And again, you're signaling the importance of the patient's point of view. That's so central to MI. So let's look at Taylor. Taylor's a 17-year-old who comes in for a physical. She recently tried cocaine when she was drunk and she had a bad experience. So she's annoyed when when the suggestion of not drinking comes up, but she really doesn't want to use cocaine again. So a negotiation would be, as your doctor who cares about your health, I recommend that you quit drinking until you're older because teens often make bad decisions when they're drunk. We both know you need to decide for yourself what to do. And then, again, how can you protect yourself from doing things you regret in the future? So you're putting the ball back in her court so she can start thinking about this. Reframing, it's exactly what it sounds like. You're taking something that's been said and you're giving it a reframe. So let's look at Donna. Donna is 15 years old. She committed to stop drinking after a suspension. She did well for a few weeks, but had a beer at a friend's birthday party last weekend. So she's probably ready to throw in the towel, and you're going to do some very positive reframing. So you say to her, you only drank once in the past couple of months. That's a really big change. So you're going to lead with a positive, not the fact that she had a slip, followed by getting more information. What was happening last weekend when you decided to have a drink? What could you do if that happened again? Are folks getting the idea of where I'm going with those examples? All right, I'm going to do one more, and then I'd like to see the effective physician, just to pull things together. So summarizing, and you kind of get better at doing this in the moment. You don't have a lot of time to practice, but you're synthesizing what's been said, and you're summarizing it. You want to reflect back on what the patient told you, and this really signifies that what he or she said to you was important. So it's a really important skill to develop. So we're going to finish with Tom, who's 19 years old. He was kicked out of his dorm because of drinking. He wants to stop so that he could go back to school. I've seen patients like this, but he's worried it will be difficult. All his friends drink. So he's going to get a job on Friday night, so he won't go to parties, and he's rediscovered a sober friend, Jake, who doesn't drink. So your summary based on what Tom has told you, quitting drinking is hard, but you've decided to do it. Your work schedule will keep you away from parties. You could spend time with Jake if you don't want to be around alcohol. It's great that you want to get back to school, so we're all about strength-based. And then what else can you do if you find yourself around alcohol? All right, so what I'm going to ask my assistants is could we then show the effective physician, just because we're almost out of time? I can find the slide. So I'm going to skip this part.
Okay.
Just keep going. It's probably about 5 more. Perfect.
Right there?
Yes. So as you're looking at this, think about what we
Watch what
just talked
happens
about.
this time when the provider cues into what the parent is saying. Find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop, but
Yeah.
they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep, every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's
and
on your
quitting
to-do
doesn't
list,
happen.
it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful.
Thank you.
Sure.
All right, folks. Well, I see that we're almost out of time, so I stopped that a little early. But I think the difference between the first one and the second one, I'm going to say, is not subtle. You see how that was very collaborative. One of the things I like the most about watching it is what the clinician was doing very skillfully is really eliciting her own reasons for change. And again, change talk. Just have that phrase in your head that if the patient is saying out loud, you know, reasons that she quit before, reasons that she would like to quit, she was able to do it before. That's really what we're going for in this brief interaction, is having, you're not lecturing to the patient about why they should stop, but you're trying to elicit from them with all of these tools in the toolbox. That's how you're kind of masterfully steering the conversation. Any questions? I realize that our time is essentially up, but I'm glad that we saw the before and after. I think that really gives a nice demonstration of what we're going for. All right, any questions? Any online questions? All right, shall we say it's a wrap? Thanks, everyone. Thank you.
My pleasure. I'm sorry it was a little rough in the beginning.
No, I was so happy when I could do it.
Yeah. Okay.
Enjoy your day.